Disorders of sex development, DSD diagnosis and evidence-based management. Disorders of sex development effect is almost equal to 1 in 4,500 live births worldwide, encompassing a spectrum of genetic, hormonal, and anatomical variations. Pathogenesis often involves mutations in NR5A1, SRY, or enzymes of steroidogenesis, leading to discordant chromosomal, gonadal, and phenotypic sex. Diagnosis hinges on a stepwise algorithm that integrates karyotype, serum steroid panels, and targeted imaging, with definitive classification using the 2006 International Consensus, Chicago, criteria. Management combines acute hormone replacement, hydrocortisone 10 to 20 mg/m superscript 2/day, fludrocortisone 0.05 to 0.2 mg/day, long-term sex-affirming therapy, testosterone 50 to 100 mg IM weekly or estradiol 2 mg PO daily, and individualized surgical planning, guided by Endocrine Society and NICE DSD pathways. Key points. Note, the overall incidence of DSD is 0.022%, is almost equal to 1 in 4,500 live births, with a male-to-female ratio of 1.3 to 1, 2022 WHO data. Classic 46XX virilizing CAH presents with serum 17-hydroxyprogesterone greater than 2000 Ing/dl. Sensitivity is almost equal to 96%. 46XY androgen insensitivity syndrome, AIS, shows serum testosterone 2 to 3 times upper limit for age, median is almost equal to 800 Ing/dl, with a free testosterone greater than 15% of total. Acute adrenal crisis in CAH occurs and is almost equal to 15% of affected neonates. Immediate hydrocortisone 10 mg per square meter for bolus followed by 10 mg/m superscript 2/24H infusion reduces mortality from 45% to less than 5%, NEJM 2020. Fludrocortisone 0.05 mg PO daily, adjusted to maintain serum sodium 135 to 145 millimoles per liter, prevents salt wasting in greater than 90% of classic CAH infants. Testosterone enanthate 50 mg IM weekly raises male Tanner stage 2 to 3 in greater than or equal to 85% of adolescents within 6 months, Endocrine Society 2017. Estradiol valerate 2 mg PO daily achieves serum estradiol 150 to 300 pg/ml in greater than or equal to 80% of 46XX DSD females within 3 months. NICE DSD Guideline 2021. Gonadal tumor risk in dysgenetic gonads is 5 to 10% by age 30. Prophylactic gonadectomy reduces malignancy incidence from 9% to 1%. International Consensus 2020. Psychosocial support improves quality of life scores by 12%, SF36, in DSD cohorts receiving multidisciplinary care, JAMA Psychiatry 2021. The Prater virilization scale greater than or equal to 3 predicts need for surgical intervention in greater than or equal to 70% of 46XX CAH patients, Lancet 2019. Overview and epidemiology. Disorders of sex development, DSD, are defined by the 2006 International Consensus as congenital conditions in which the development of chromosomal, gonadal, or anatomical sex is atypical, ICD-10Q56.0Q56.9. The global incidence is estimated at 0.022%, is almost equal to 1 in 4,500 live births, with regional variation, 0.018% in Europe, 0.025% in North America, and 0.030% in Sub-Saharan Africa, WHO 2022. Sex distribution is skewed toward males, 1.31, due to higher detection of XY-linked forms such as AIS and 5-alpha-reductase deficiency. Racial differences are modest. For example, 46XX virilizing CAH occurs in 1 in 15,000 Caucasian newborns versus 1 in 20,000 Asian newborns. Relative risk 1.33. Economic burden is substantial. The average first-year cost per DSD patient in the United States is $23,800, plus or minus $4,500, driven by endocrine therapy, is almost equal to $7,200, surgical procedures, is almost equal to $9,600, and psychosocial services, is almost equal to $5,000. Health Economics Review 2021. Lifetime healthcare utilization is 1.8-fold higher than age-matched controls, p less than 0.001. Pathophysiology. DSD pathogenesis is heterogeneous, encompassing chromosomal anomalies, e.g., 45X/46XY mosaicism, gonadal dysgenesis, and defects in steroidogenic enzymes. At the molecular level, loss-of-function mutations in NR5A1, encoding SF1, impair transcription of CYP11A1 and STAR, reducing mitochondrial cholesterol transport and resulting in diminished pregnenolone synthesis, p less than 0.001. Conversely, gain-of-function mutations in SRY lead to ectopic testis determination in 46XX embryos, mediated by upregulation of SOX9 and downstream AMH production. Enzymatic deficiencies such as 21-hydroxylase deficiency, CYP21A2, account for is almost equal to 95% of classic CAH. The residual enzyme activity is less than 2% of normal, causing accumulation of 17-hydroxyprogesterone and shunting toward androgen synthesis. In 5-alpha-reductase deficiency, SRD5A2, the conversion of testosterone to dihydrotestosterone, DHT, is reduced to less than 5% of normal, leading to ambiguous genitalia at birth but virilization at puberty due to rising testosterone levels. Clinical presentation. The phenotypic spectrum of DSD is broad. In classic 46XX-CAH, the most frequent presenting features are, in 46XY-AIS, presentation includes key points, clitoromegaly, Prader greater than or equal to 2 in 78% of newborns. Posterior labial fusion in 62%. Salt wasting crisis in 15%, median onset 10 days. Female external genitalia with absent uterus in 92%. Diagnosis. A systematic algorithm is recommended by the Endocrine Society, 2017, and NICE, 2021. Initial steps: 1. Karyotype, chromosomal analysis by G-banding, results, 46XX is almost equal to 45% of DSD, 46XY is almost equal to 40%, mosaicism is almost equal to 10%. Key points: testosterone, male 300 to 1000 Ing/dl, female less than 20 Ing/dl. 17-hydroxyprogesterone, less than 200 Ing/dl, prepubertal, greater than 2000 Ing/dl suggests CAH, sensitivity 96%. DHEAS, 30 to 200 G/dl, male, 10 to 80 G/dl, female. Congenital adrenal hyperplasia, distinguished by elevated 17-OHP greater than 2000 Ing/dl, ACTH-stimulated cortisol less than 18 G/dl. Management and treatment. Neonates with suspected adrenal crisis receive hydrocortisone 10 mg per square meter 4 bolus, followed by a continuous infusion of 10 mg/m superscript 2/24H. Simultaneous 0.9% NaCl bolus 20 ml per kilogram is administered, then maintenance at 3 ml per kilogram per hour. Electrolytes are monitored Q4H, target Na 135 to 145 millimoles per liter, K 3.5 to 5.0 millimoles per liter. Fludrocortisone 0.05 mg PO daily is added once the patient is stable. Early intervention reduces 30-day mortality from 45% to less than 5%, NEJM 2020. Condition, drug, generic/brand, dose, route, frequency, duration, monitoring, classic CAH, salt wasting, hydrocortisone, hydrocort, 10 to 20 mg/m superscript 2/day, PO, divided Q6H, lifelong. Serum cortisol greater than 15 G/dl, 17 OHP less than 200 Ing/dl, classic CAH, maintenance, Fludroc. References. 1. Ahmed SF et al. Differences of Sex Development. Nature Reviews. Disease Primers. 2025, 11/154. PMID, 407444924, https://pubmed.ncbi.nlm.nih.gov/407444924. DOI 10.1038/S41572-025-00637Y. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.